My name is Chiara De Poli. I'm a research officer at the Care Policy and Evaluation Centre at the London School of Economics and Political Science. The study we did in Durham was an action research study, by which we mean a research project where we bring together different groups of stakeholders. In our case, we involved people living with dementia, family carers of people living with dementia, service providers, commissioners of health and social care services, local authority, third sector organizations working in the dementia care space. And the aim of the study was to bring them together and discuss ideas, options for improving how dementia care was organized at the local level. And the starting point of the work was really the actual experience of people living with dementia and carers. So we interviewed a few of them, and we tried to identify, given their accounts, what was working well in the local level for people living with dementia, and what wasn't working that well. And based on the first phase of the work, we identified two areas really that needed improvement. And one was a fairly basic one, which was around the fact that people couldn't find the information they needed at the time they needed it. In the diagnostic phase, in the initial phase of the work, we realized that, well, we had a fairly mixed group of people. So some people were better off in some ways, others were living in more rural areas, others were living in more urban areas. And the picture we got from these accounts was one where some people seem to find, they seem to be able to navigate the system very, very well. And this might be explained by different factors, often in combination. So it could be either because they had, in case of people living with dementia, they had a carer who could help them out, and they could be they would help them in day-to-day activities, but they would also, those who would put in place advanced care planning things, or they would manage finances and these sorts of things. And in case people didn't have an actual carer, they could find a professional, usually working wherever in the dementia care system, who could help them in a very practical way. Based on the results of that first diagnostic initial phase of the study, we realized that one, people couldn't find the information they needed, and they might need information around different things. The second bit was the second issue was around sources of information. So people wouldn't know where to go to, given what information they wanted to find or they felt they needed. And the third bit was around, or the third issue was around the timing on the information. So typically people would say there was an overload of information at specific points in time, usually around the diagnosis. It's pretty standard. But then they felt that over time they weren't really offered or reminded of given the information they would need as the disease progressed, and where maybe needs change and family circumstances changes. And we addressed this problem in a very simple way, which was we co-designed a leaflet about care and support services available to people living with dementia and family carers of people living with dementia. And we co-designed every aspect of it, from the title, from the language we used, to the level, we discussed the level of details of information we wanted to include. And we also discussed how this leaflet should have been disseminated in practice. And another research study we are working on at the moment is Stride England, and which is based in England. We take a national approach in what we are doing, and the aim of Stride England is to work with people living with dementia, family carers from a hard-to-reach population, and hard-to-reach populations defined using a mix of criteria or variables. So it could be people from ethnic minority groups who have been diagnosed with specific types of dementia. It could be people for whom English is not the first language, and or might have living arrangements which are interesting to observe. For example, they don't have a family, they don't live with a family member, they live on their own, and that might trigger a number of issues in the way they experience dementia care and support. The assumption often is that every person with dementia has a carer, has a family carer, and often this is not the case. So we are really looking at groups that are, given their socio-demographic profile, they are, or they could be at higher risk of experiencing unmet care needs and health inequalities. In Stride England, I'm the lead of the qualitative research package, which means we are, as part of Stride England, we are doing about 70 interviews with a mix of people living with dementia and family carers, and we are trying to interview each participant twice, so in the end it's going to be more than 140 interviews. And I'm leading the data collection. We completed fieldwork in about 3 sites, so we've done so far more than 30 interviews, and we are planning to, and in with some participants we have already done second interviews, so we're going back to them, sharing the results of our analysis and providing some feedback about the data we collected from them, and making sure that the way we are representing the stories and the data is accurate from their perspective. We don't want really to overimpose our interpretation on their experiences and on their stories. Possibly the main issue we have been experiencing so far is making sure that we reach those hard-to-reach population, which are hard to reach for obvious reasons, and this means that it takes longer, more effort to make sure that we make contact with them. And in our experience, once we succeed in making contact with them, people are very generous with the story, and they are very keen to take part, and they are very keen to see how their interview or whatever they are sharing. And something that has stayed with me lately, with one interview we did recently, was around, for example, a person who diagnosed with dementia in older age, extremely active, engaged in many groups and support activities available in the community, and she was living at home with another family member who would help her. No major care needs, nothing substantial, but certainly she would need help with few bits. And at some point, though, the carer developed health issues of their own, fairly serious as well. And the person with dementia became the actual carer for the carer. And when we interviewed them, we were really navigating this kind of switching roles, and the person with dementia going out, they told us that the person with dementia would go out and go shopping and do the grocery shopping. She would cook for what she could, and she would go with the carer to medical appointments, because the carer can't really, she's not really mobile, and she struggles with that. And it was really interesting to see how people adjust when care needs change, not just for the person with dementia, but also for the carers themselves. So often we tend to look at, define health inequalities looking at some socio-demographic variables, ethnicity, age, gender, whether people self-identify from LGBTQ+ community, for example. But I think it's important to remember that health inequalities might change over time, and people might start from a position of advantage somehow. And over time, this Dementia Action Week is important to remember that there is no one-size-fits-all approach in dementia care and support.